As always, we'll start off with Patrick. Patrick Kinghorn, are you there? Can you give us all a little primer on how to use the WebEx system?
I am here. Welcome, welcome everybody. Like always, we like to give a little background on our WebEx software that we have here. I'm going to go ahead and annotate, so you're going to see a little laser pointer. Welcome to our roundtable. So you might need surgery for skin cancer. What does that mean? My name is Patrick Kinghorn, and I work at OHSU in the Department of Dermatology. And like I said, we're going to go over some quick instructions on the WebEx. You should be seeing my screen, which looks like your conference window. And you'll see a few main commands, which are the circular icons on the bottom of the screen. Firstly, the icon with the microphone on it controls your microphone on and off. And this video button turns your video on and off. Both of these should be red as they have been disabled, and to avoid unwanted distractions during the conference, please keep these functions off unless you're prompted to. Next, we have the Participants tab, which opens and closes the Participants tab, and the chat button. The chat button is particularly important because this is going to be your main way to ask questions or to engage throughout the conference. So please feel free to use the chat box function here to be able to ask all your questions, and we'll do our best to get to all of these. Otherwise, that is the majority of my little spiel, and go ahead and turn it back over to Dr. Leachman to introduce our speakers.
Great. Thanks very much, Patrick. So as you heard, the title of this roundtable is So You Might Need Surgery for Skin Cancer. What does that mean to you? And we're really fortunate today because we got two of the surgical leaders from our melanoma program to agree to speak with us today about their perspectives on this. And there's two speakers, and I wanted to just maybe start the introduction of these two speakers to explain the difference between the two kinds of surgery and kinds of surgeons they are. Dr. Barr, Anna Barr, is a dermatologic and Mohs surgeon. And so her role in the process of melanoma, as you'll see in her talk, she is taking care of patients with some of the earlier stage of melanoma, stage 1 and 2, and those patients, most of the time they need surgery, just a local surgery. They're not going to need internal surgeries or surgery in their lymph nodes. And those patients are sometimes very challenging, as you'll see, and they need reconstruction. And so she's oftentimes kind of like what you think about with a plastic surgeon, somebody that can really not only identify the tumor, and she'll tell you about how she can assure that she gets it all out, but also is someone that can close it with a great deal of cosmetic cosmesis. And then Dr. Hahn, Dale Hahn, he's our surgical oncologist, and Dale is the person that sort of takes care of a little bit later stage, more of the stage 2, stage 3, and stage 4 patients with melanoma. And those patients are the ones that need sentinel lymph node biopsies or lymph node dissections, or perhaps something because of a metastasis to another organ. And so so they're different kinds of surgeons, and I think that hopefully what we'll be doing in today's roundtable is going through the entire spectrum of surgical needs, so that then at the end, when we ask that, so it'll be Dr. Barr first, and then it'll be Dr. Hahn, and then we'll go into the question and answer session so that we can hopefully bring it and tie it all together, so that regardless of what your questions are about surgery for melanoma, we'll be able to answer them with the experts, the actual people who are the experts in the field. So with that, I will turn it right over to Dr. Barr. Anna, are you ready to go?
Wonderful. Yes, thank you so much. I'm going to share my screen. I have a PowerPoint here. All right. Hopefully it will share the right thing. Okay. Slideshow. Okay, so I'm going to get started today, and I'm going to be talking about using Mohs surgery for melanoma, which is something that we do for early stage melanomas that, as Nancy mentioned, don't need the internal surgery that Dr. Hahn does. And I'm an associate professor of dermatology at Oregon Health and Science University. Some of you may have seen our melanoma campaign that encourages you to detect early stage melanoma when it's the most curable. And a lot of you have seen the messages and graphics that the Warren Melanoma has put together, the cancer that you can stop with your eyes. So what is Mohs for melanoma? I'll tell you about it, and I'll tell you some of our advances that we've made at Oregon Health and Science University over the past decade treating this disease. So when do we talk about Mohs for melanoma? Well, a lot of you may know about Mohs for other skin cancers like basal cell carcinoma, but not everybody knows about Mohs on the face for melanoma. And that's because it's not done everywhere. There are only selected specialized centers across the country that can perform Mohs for melanoma. So not everyone is trained in it or using it, but we have found that it can be an excellent technique to use on the face or other selected areas such as the scalp, where the melanomas can be very tricky and cosmetic result is of the paramount importance. So what is Mohs? Well, it's a type of surgery that's named after the surgeon who invented it. His name was Fred Mohs. And he developed the technique at looking at the entire margin in the 1930s at the University of Wisconsin. When we remove the tumor, we cut it in such a way that we look at the entire deep margin and the entire peripheral margin of the tumor at the same time. So when you see a skin cancer on the skin, sometimes it's just right there on the surface, and sometimes it's not. So with Mohs surgery, we can track it out, and we take off a layer, we check it, we see, oh, look, there's a little bit left in this side, and we go back just right to that side and take a little bit more, or just take a little bit deeper until we can achieve clear margins, which, as you know, achieving clear margins on a tumor is pretty important. Well, that makes sense, right? So why do a lot of centers not use it on melanoma yet? Well, when we do Mohs surgery, we make frozen sections, which takes about an hour to make. And melanoma, as you can see on the left, isn't as obvious on these types of frozen sections. And the melanomas that we treat on the head and neck seem to be a special category of melanomas that on the sun-damaged skin, they can extend beyond where the brown pigmentation is. And we find that that is the case very frequently on the face. So the other consideration is that people want the best cosmetic results. So coupling with that with, we want to take the small margins possible, but these melanomas seem to go on farther than the others, it really leaves us in a conundrum. But we have this amazing new advance in the melanoma treatment where we can use these immunostains, and this is what not all centers are trained to do. We use these immunohistochemical stains to highlight the melanocytes so that we can better see the tumor on the frozen sections. So now the old traditional way would be very hard to see those cells. And in the new way, I think everyone can see those cells, which is a really important thing when we're trying to remove the melanoma with very precise margins. So currently, the melanoma treatment margins are depending on the depth of your melanoma. And if it's an earlier melanoma, they recommend like a 1 centimeter margin or less. And if it's a later stage melanoma, they could even recommend 2 centimeter margins around it. But that's not always possible on the face. That, could be disfiguring. And the way that the margins are checked, is a little bit different when it's cut out with a big margin. So it's not, it's a great technique, but we're evolving in our treatments of melanomas where we're really focused on removing the tumor with precise margins. So many studies have shown that Mohs has a very good survival benefit for patients with early stage melanomas when it's combined to traditional wide margin excisions. And many of the patients had no local recurrences of the skin cancer. In fact, the rate of local recurrence was actually better than when bigger margins were taken or the margins were taken as an excision. So you could see this is kind of a summary of the studies of the recurrence rates for Mohs surgery of melanoma in situ, which is the surface type of melanoma that hasn't invaded. And you could see at the bottom our OHSU data. We have one of the largest series ever published for treatment of melanoma, where this is our data for 10 years, 2007 to 2017. With 669 patients and a very, very good survival rate and a very, very low recurrence rate of less than 2.5% before we instituted the advanced immunohistochemical staining, and even lower after we have instituted that advanced test. So this was published widely in the dermatologic surgery literature. And that's all of our data all combined and how we did it. So we got our results out to the world so they could see the kind of technique that we're using here at OHSU. And like I mentioned, you won't find it in Seattle. You won't find it. There's only one center in New York that does it. You're not going to find it everywhere. But we're lucky that we've been doing it for a long time here in Portland. And this kind of a summary of our results, which I don't have time to really get into the nitty gritty, but we did mostly treat shallow melanomas. 535 were in situ and 133 invasive melanomas. We did have difficult melanomas. Almost 10% of them were recurrent after a prior treatment. And they were mostly 77% were on the face, 13% on the scalp, 3% on the neck, and 7% on the trunk and extremities. We were able to achieve same-day reconstruction in a third of the melanomas, and that was in 2017. But now I would say it's more like 75% that we can achieve same-day reconstruction. And as I mentioned, the survival benefits of using this technique for the patients was very, very good. We had very few deaths and very few recurrences. That's just another table. We really broke down and divided out the data of the depth of melanoma, the location of melanoma, and really looked at everything closely to make sure that our technique was a very good, accurate technique to be using, and it was. So one of the problems with head and neck melanoma that I mentioned was that they often extend out beyond where the brown spot is. And that is why we've had a lot of trouble with head and neck melanomas in the past. So with Mohs surgery, we're able to start with a normal 5 millimeter margin, but in some cases that's not enough. So we have to take a little bit more. And we found this, and other people have found this as well. Most studies have found a mean margin of like 7 to 9 millimeters is required to resect melanoma on the face. Now, not everyone, needs that much, but some people do. And with the Mohs surgery, we're able to find out if they need more, then we'll take a little bit more that same day, rather than having them come back in a week and tell them, oh my gosh, we didn't get it all. This is the way that we have more assurance of getting it all. When we looked at the different size and margins on the head and neck, the mean margin for excision was about 7.2 millimeters. And it didn't seem that it was very significantly different between in situ and invasive melanoma, which was very interesting. And again, showing the 5-year survival rates with the Mohs surgery are very, very good, equal or better than a wide excision. I have a lot of cases because many times I'm giving this talk to other doctors at some of our surgical meetings, such as our Mohs surgery meeting. So I'm not going to show you all the cases. They can get pretty intense, but I'll show you just a few examples. So when we start with Mohs surgery for melanoma, we sometimes use this special light that highlights the melanin that, that makes up the pigmented or the bad cells of the melanoma. So this is a UV lamp, and it highlights the epidermal pigmentation. So you can kind of see just how extensive this melanoma is. It doesn't look like much when you look with the regular light, but then you look at it with the UV light and you could see that it's a little bit more than what you thought. And there are melanomas that don't even have any pigment at all, ever, to start with. And this is a type that can occur on the face. So this was a lady she never even had a brown spot. She had a pink spot on her face. It was biopsied and shown to be a melanoma. And this is my stains that I did during her surgery. I started out with a 5mm margin and it wasn't quite clear. You can see that in the first Mohs stage that there are way too many of those melanocytes present. So I had to go back and take a little bit more. So finally, by the time we got it clear, this was the size, and we're able to stitch it up same day with a closure. And there she is at 1 month, healing up very well. Another case where the melanoma had very light pigment and was not terribly obvious to the naked eye. But after all the reconstruction and stitching, there's his tumor you can see on the melanoma. And now by the third stage, I could see that the tumor was clear. So this is the normal density of melanocytes in your skin. And there he is when he's with his defect, but then all healed up after 2-3 months. It's a very good looking cosmetic result, and the scar does continue to get better for about a year. It can be used in old patients, young patients. This technique can be used in many people. Here's another spot that really was not very pigmented. And as you can see, I tried to start very, very small on this one, but unfortunately his melanoma was really, really extensive. Anyway, we were able to remove it and stitch it up. And there he is at 1 month healing. Here's a melanoma that had come back after 17 years. And this patient was referred to me for this recurrent melanoma. We were able to remove the melanoma on the lip, completely remove it. I stitched it up. And this is his healing course. And as you can see, these wounds take a little bit of time to heal. There he is at 1 month, but there he is at several months. And it has a very good cosmetic outcome where most people can't really, tell. It's not really obvious that there is much of a scar. Okay, so Patrick, I think is that probably it for my time? I could talk for 2 hours about all my cases, but I don't want to take time away from the other speakers. So
I think that's great,
yeah.
Anna. I think that's wonderful. And I think that one of the things that it shows, I hope, that people see is that having a diagnosis of a melanoma on your face doesn't necessarily mean that you're going to be disfigured afterwards. And I think it was really impressive to see the level of skill that you've developed in terms of not only removing all of the tumor, but also in getting the closure to heal in a way that doesn't cause major disfigurement that you might think. So thank you for that. I think we're going to go on and go to Dale now, but I do see some questions that have been asked that have been sent in for you. So we'll come back to those in just a minute. Dale, are you ready to proceed with some of the more extensive surgical treatments?
I am indeed, and thank you for having me here. It's certainly a pleasure to be talking here, and I appreciate the opportunity. I'm going to just share my screen here. Let's see. All right, can you see my screen?
Yep, looks good.
Okay, great. So Dr. Barr did a great job discussing some of the early treatments of melanoma. I'm going to focus a lot of my talk and there's a lot of things to talk about. So I'll try to compress this in a short period of time, discussing primarily management of nodal disease and disease at distant sites. I have no disclosures. I show this slide to remind us that the incidence of melanoma has been increasing every year, with a 600% increase in melanoma between 1950 and 2000. And so now melanoma represents, based on the 2018 Cancer Statistics Guideline, the number 5 incidence of cancers in males, number 6 in females. In 2013, based on the cancer statistics at that time, it was the most common form of cancer in ages 25 to 29. And the other thing to remember is that the vast majority of these newly diagnosed melanomas are what we call thin cases, or melanomas that have a thickness of up to 1 millimeter. In this slide, basically, is to emphasize the point that the vast majority of patients who are newly diagnosed with melanomas present only with localized disease, meaning disease that we know of at the primary site where it develops. Only about 9% of patients actually have regional disease, and many of these patients have more advanced forms, and less than 5% of patients who are newly diagnosed have any form of distant disease. Now, there are several factors that have been correlated as prognostic markers predicting survival in patients who are diagnosed with melanoma. Factors with the local disease, such as Breslow thickness and ulceration status, but also whether or not there is microscopic spread of melanoma to the regional lymph nodes. Now, as Dr. Marr had mentioned, the treatment of melanomas consists of wide local excision using various techniques, either surgery or a Mohs surgery, particularly in specialized areas, as Dr. Barr has mentioned. And the margins utilized are as listed here, and also as Dr. Barr had shown in her slides. We basically resect down to fascia, and then we close the defect in various ways. And the reasons why we do this is not only to obtain negative margin, but also to eliminate any microscopic cells that may be emanating out from that primary site. So as Dr. Barr had mentioned, we basically remove the melanoma site. We can close it primarily, as shown in this slide, or this top set of pictures. We can or use a flap closure in this picture, or skin grafts as needed. But really, the meat of my talk is going to focus on the nodal status for patients who've been diagnosed with melanoma. And as I mentioned, nodal status, or whether or not melanoma is or is not seen in your lymph nodes, is prognostic for survival, and that's why we've incorporated it into the staging systems for melanoma. But the problem is only about 15 to 20% of patients are ultimately found to have microscopic disease in the lymph nodes. And in the past, we used to routinely do something called elective lymph node dissection, where we would just choose patients who we think were at high risk for disease in their lymph nodes and just remove those lymph nodes, not knowing whether or not there was actually melanoma in there. So many patients were actually unnecessarily exposed to the risks and morbidity of this procedure without having a proven survival benefit, because multiple studies have shown doing this procedure actually provided no survival benefit. So in 1992, Don Morton et al. Introduced the technique called sentinel lymph node biopsy, which was a less invasive way to evaluate nodal status in melanoma patients. And the hypothesis behind this technique is that each area of skin drained to specific lymph nodes, and by finding the first draining lymph node within that basin, we term that lymph node as the sentinel node, because it would be the first most likely harbor any metastases that had spread along the lymphatics. By assessing this sentinel lymph node, you can determine the status of the entire lymph node basin, meaning that if it was negative, the entire basin was negative. If it was positive, it doesn't matter. The whole basin is positive. So how's this technique done? We first utilize localizing agents, which we inject into the skin around the tumor. These agents then accumulate in the fluid around the tumor bed and drain via lymphatics into regional lymph nodes. These agents accumulate in those first order nodes, which we locate, make small incisions, find and remove those sentinel lymph nodes. Now, in order to do this technique, we utilize several tracers to be able to determine the lymphatic drainage and ultimately the sentinel lymph nodes. One type of tracer is a radio tracer, which gets injected in nuclear medicine, and we often get a picture called lymphoscintigraphy to show us where those drainage patterns are, or where the sentinel lymph nodes are located. We then utilize that radio tracer and detect it during surgery using a small gamma probe to find those sentinel nodes. We also utilize vital blue dyes, and there are various agents that we can utilize. And basically what we do is we use this in surgery to actually look for blue draining lymphatics that drain into blue lymph nodes. And those are determined to be the sentinel lymph nodes. Now, when we utilize both radiotracer and vital blue dye together, we found that the identification rate is on the order of 97 to 99% for finding sentinel nodes. So in doing this procedure, what would you expect as a patient? Well, both procedures, meaning the wide local excision and the sentinel lymph node biopsy, can be done on the same day. It's done under general anesthesia, but it's an outpatient procedure, and most patients go home from the recovery room if you meet criteria for being able to go home. Now, in order to get ready for the surgery, you need to get some preoperative studies because you will be under general anesthesia. Generally, you have nothing to eat after midnight. And you basically are evaluated by the medical folks to make sure that you're optimized and ready for surgery, have blood thinners stopped, and do other things to get ready. Now, the other thing to note is if you have the nuclear medicine injection done on the same day, this becomes a full day event because you go to nuclear medicine to get your injection, get your picture taken, then come to the pre-op holding area, and then you go to the operating room. And then it's about, after everything's all done with the wide local and sentinel node biopsy, you then have about a 2-hour recovery after you wake up from the anesthesia. So why do we do sentinel lymph node biopsy? Well, the study that really put this on the map is something called Multicenter Selective Lymphadenectomy Trial 1. And what this study basically did was it randomized patients with a melanoma to either having a wide local excision and just observing the nodal basins, meaning no procedure, versus wide local excision, sentinel node biopsy, and the lymph node dissection surgery afterwards if you had a positive sentinel node. And what they saw was that in patients with intermediate thickness melanomas, that is melanomas between 1 and 4 millimeters in thickness, survival differed significantly based on whether or not your sentinel node was negative versus positive. If your sentinel node was positive, then you had significantly worse survival. And this was in the intermediate thickness group and also in patients with thick melanomas, which are melanomas with a thickness greater than 4 millimeters. So basically what this tells us is this is a very important prognostic tool at this point. And in fact, this was confirmed when they did a multivariable analysis. And what they showed was that whether or not your sentinel lymph node contained melanoma was the most powerful predictor of recurrence of melanoma and death from melanoma. So basically what we can say for sentinel node biopsy is that it is a crucial staging tool that provides significant prognostic information, although the therapeutic effect of removing these sentinel nodes, we don't quite know ultimately, although there is some kind of backwards way of looking at the data that suggests there may be actually. So the complication rate from sentinel node biopsy is about roughly 5% based on the Sunbelt melanoma trial. The MSLT1 trial actually showed it to be closer to 10%. And the rate of lymphedema or swelling of an extremity, because these lymph nodes filter fluid back from parts of the body. So if you start taking them out, that fluid can back up and create what's known as lymphedema. That rate is less than 1% because we're only removing a couple of sentinel nodes. That rate was also similar in MSLT1's data. So what we can say is for patients with intermediate thickness melanoma, meaning melanomas that are between 1 and 4 millimeters in thickness, well, this is the primary group that was evaluated. And it had doing sentinel node biopsy in this population provided powerful prognostic information. The positive sentinel node rate in this group was about 15 to 20%. The complication rate is about 5 to 10%, and the false negative rate is about 10 to 15%. The other things to remember is that by determining the nodal status for a patient, this allows for potential regional disease control in select patients. And also, if you have a negative sentinel node biopsy, that spares those patients any further therapies that they wouldn't have benefited from. The other thing to remember is that the lower number of nodes that you harvest through a sentinel node biopsy, because we're usually only taking about 1 to 4 nodes, this allows us to more rigorously examine each of those nodes to determine if there's a metastatic focus. So how about patients with thicker melanomas, over 4 millimeters in thickness, what we call thick melanomas? Well, there's a little bit of debate about using sentinel node biopsy in this population because about 30 to 40% of these patients will ultimately develop disease elsewhere in the body. So, finding out if there's melanoma in the lymph nodes may have some limited utility in this population. But a certain subset of patients with these high-risk melanomas will still only harbor disease in these lymph nodes. So doing a sentinel node biopsy may actually be beneficial in these patients. So this is actually the largest study that's been done on thick melanomas. And what this shows is that in over 1,200 patients, there was a significant prognostic value to doing sentinel node biopsy because positive sentinel node patients, as shown in the blue, had significantly worse survival compared to negative sentinel node patients. And on multivariable analysis, the status of sentinel lymph nodes, meaning if they were positive versus negative, was the most powerful predictor of survival in these patients. So if you also do a deep dive of most of the studies that have been done in thick melanomas, as shown by the shaded red, most of these studies actually showed that positive sentinel node patients in thick melanomas actually did much worse than negative sentinel node patients. So again, we can say for thick melanoma patients that there's very important prognostic information provided by sentinel node biopsy. It also allows evaluation into clinical trials and potential treatment with additional therapies such as immunotherapy, and also allows potential regional disease control in select patients. Well, how about the other end of the spectrum? Thin melanomas. Melanomas are up to 1 millimeter thickness. Well, as we mentioned, this is a big problem because the vast majority of newly diagnosed cases are thin. And most of these patients actually have a very good prognosis with 10-year survival rates of over 90%. But the use of sentinel node biopsy in this population is a little bit controversial. And that's because only a small percentage of these patients do poorly. And we don't know the ultimate prognostic value of sentinel node status in these patients. And there have been a lot of studies looking at it. I'm going to just list a couple here in this very complicated slide. But this is basically showing that lots of studies have been done on this, trying to figure out which patients may benefit the most from sentinel node biopsy and those that have a thin melanoma. There are primarily 4 different category or characteristics that have been delineated in multiple studies as probably being more prognostic for a positive sentinel node, but really it's thickness greater than or equal to 0.75 millimeters. And really that's 0.8 millimeters in thickness based on the new staging criteria. And so at this thickness, once you get to 0.8 millimeters, your risk for a positive sentinel node becomes 5% or more. And it's at the 5% mark that we start to offer the procedure. Not necessarily we recommend it, but we start to offer it because the 5% rule allows you to offset the 5 to 10% complication rate, the 5 to 10% false negative rate of the procedure. And so that's the reason why we utilize that 5% rule here. So based on all this, the Society of Surgical Oncology and ASCO published guidelines basically saying that for anyone with an intermediate thickness melanoma, as long as you're healthy enough for general anesthesia and you're clinically node negative, that you should have a sentinel node biopsy if you have an intermediate thickness melanoma. For patients with thicker melanomas, sentinel node biopsy may be recommended after you have a thorough discussion of the risks and benefits. But for patients with thin melanoma, routine use of sentinel node biopsy is not recommended, except for patients who have higher risk disease, i.e. a 5% risk or above. And those consist of patients who have melanomas that are 0.8 millimeters or above, or less than 0.8 millimeters with ulceration or other high-risk factors. So how about lymph node dissection for melanoma? This used to be a big thing for surgeons back in the day, but this has changed dramatically. Currently, for patients who come in with overt evidence of disease in the lymph nodes, meaning you come in with, let's say, a palpable node in your armpit, you have 2 choices of therapy. The first is either you can do upfront surgery where you remove all the lymph nodes in that lymph node base and then follow that potentially with additional therapy like immunotherapy, or you can start with these systemic therapies such as immunotherapy and then potentially have surgery afterwards. So that is a different kind of beast, and I'll shelve that part. What I really wanted to talk about is how about patients who have microscopically detected disease, meaning disease that was found on a sentinel lymph node biopsy. So in the past, we used to routinely always go back in and say, hey, you've had a positive sentinel node. We need to go back in and remove the rest of the lymph nodes in your basin. And the reason why we did that was because of trying to obtain what's called regional disease control, meaning if there was additional nodes with melanoma, we wanted to make sure we got it all out. But we ultimately didn't know if this provided a survival benefit. So the study that really altered the management of positive sentinel lymph node was multicenter selective lymphadenectomy trial 2. And in this trial, they basically randomized positive sentinel node patients to either observation of the neural basins versus this completion lymph node dissection. And what they showed was that in patients with a positive sentinel node, whether or not you did or did not have a lymph node dissection made no difference in your 3-year melanoma-specific survival. And more importantly, they couldn't find a certain subgroup of patients that could benefit from a lymph node dissection. However, on the other end of the spectrum, they did find out that patients who did have that completion lymph node dissection had better disease-free survival and also had better regional or better nodal basin control rates, as would be expected. The other thing to note is that when they did their analysis looking for predictors for outcomes in patients who had a positive sentinel node, what they found was that patients who had additional nodes with melanoma in those patients who had a completion lymph node dissection actually had much worse survival. So similar or analogous to the sentinel node biopsy data, doing the completion lymph node dissection did provide important prognostic information. So to summarize all this, there is some benefit for doing additional surgery in positive sentinel node patients because it improves regional disease control. Non-sentinel lymph node status is important prognostic, provides important prognostic information, and there's also significant improvement in disease-free survival. But that is outweighed by the fact that there was no survival advantage in performing this procedure, and no subgroup was found that could benefit. So ultimately now, the use of completion lymph node dissection in positive sentinel node patients is based on a thorough discussion with patients and clinician judgment. And there are several centers now that no longer offer this procedure for positive sentinel node patients. The other thing to note is that, it's ironic that this trial actually supported the survival benefit and therapeutic effect of doing a sentinel node biopsy alone. Remember, earlier on in my talk, I talked about removing these sentinel nodes. We didn't know if that provided a therapeutic benefit, but because most patients with a positive sentinel node have one sentinel node, positive node with melanoma, by doing a sentinel node biopsy, you remove that one node, and that's actually potentially therapeutic. So based on this, the SSO ASCO made guidelines and said that for patients with low-risk microscopic nodal disease, either careful observation or completion lymph node dissection can be offered. But for higher risk patients, and what defines higher risk, we're still figuring out, careful observation can be offered only after you thoroughly discuss the risks and benefits of not doing a completion lymphadenectomy. Now, the other thing to note is that actually many positive sentinel node patients are now treated primarily with adjuvant immunotherapy or targeted therapy, meaning therapy you either take orally or through your veins without having a completion lymph node dissection. I'm almost done. I have 3 more slides here. So how about surgery for distant metastases, meaning melanoma that has spread to other areas of the body, where there's in general and historically a more limited role for surgery in stage 4 disease, mostly because the cat's out of the bag at that point. And that's because it's relatively easier to try to treat the disease you can see, but it's much more difficult to try to treat the disease you don't see, the microscopic disease that is probably potentially circulating around and put you at a higher risk for recurrence. So for these reasons, most of these patients with stage 4 disease are treated with systemic therapy. But for those highly selected patients who are treated with surgery, for patients who have multiple areas of distant metastases, survival after doing this procedure that we call a metastasectomy is about 15 to 30%, so it can be significant. And some select stage 4 patients may benefit from this. Now, in this current era, which is now different from what these other studies show, it's different because we have effective systemic therapies that are available, and therefore more stage 4 patients are becoming candidates for surgery for curative intent, meaning that there is only a few sites of disease left that we can remove surgically and basically making with no evidence of disease, or to resect what's known as treatment-resistant lesions. And more importantly, we're better able to select out stage 4 patients who will potentially benefit from metastasectomy. So as I mentioned, there was a study, or in this era, new effective systemic therapies. There are now studies coming out to talk about the efficacy of surgery in combination with systemic therapies. In this study, they looked at surgeries done during the era before effective systemic therapies and surgeries done after the advent of effective systemic therapies. And there was significantly improved survival in the patients who were treated with surgery in the after the introduction of effective systemic therapies, and more surgeries were done for curative intent. And this was stratified across all substages of stage 4 disease. So in summary, most patients present with localized disease, with the majority of new cases being thin melanomas. Surgeons continue to play an essential role in treating localized melanoma. The primary disease is treated with wide local excision using appropriate margins through either surgical techniques or Mohs procedures. Sentinel lymph node biopsy is done for nodal staging. It is extraordinarily important prognostic for survival. It's recommended for patients with intermediate thickness melanoma and may be recommended for patients with thick melanomas and can be considered for higher risk thin lesions. Completion lymph node dissection or careful surveillance can be offered to patients with a positive sentinel lymph node after thoroughly discussing the risks and benefits. And there are now adjuvant systemic therapies available to treat positive sentinel lymph node cases. And finally, the use of efficacious systemic therapies, the role of surgery with the use of these new efficacious systemic therapies, the role of surgery for stage 4 disease is expanding as selection criteria improve. More patients become potential metastasectomy candidates. Thank you.
Wonderful, wonderful. Thank you so much, Dr. Hahn and Dr. Barr. I have some really good questions. I think one of the things that I really appreciate is that we've got such great, not just expertise, but the science to back the decision making that both of you guys are doing, and you shared quite a bit. I'd like to encourage, we have some questions that were submitted, and I'm going to start with those, but I would encourage anyone who wants to ask any additional questions now that you've heard about some of the data to just submit it in the chat if you want, and I'll try to read those questions out too. And I also note that Dr. Berry, who is, we've mentioned that both Dr. Hahn and Dr. Barr are surgeons. They're part of our surgical team, but we have medical dermatologists and we have medical oncologists that are also involved. And I see that Dr. Berry is on the line as well. And I thought I would start the ball rolling by having, if Dr. Berry, can you maybe say what kind of patient you might refer to Dr. Barr or to Dr. Hahn? What's the difference between the type of patient that you refer to these two different types of surgeons?
That's a great question, Dr. Leachman. So generally when I do a biopsy of something that looks suspicious for melanoma and I start to think about the result when it comes back as a melanoma, the thinner melanomas that are sort of less than 0.7 millimeters, generally I will automatically send to Dr. Barr unless there's something funny about them. There's something funny about the history, and I won't go into those details. Anything that's 0.8 millimeters and above, I will start the conversation of sending that person to Dr. Hahn, because the likelihood, as he discussed in his talk, of having lymph node involvement starts to go up after the 0.8 millimeter mark. If somebody has a really extensive melanoma on the face, we really like to get Dr. Barr involved as well, or a very large melanoma somewhere else, because I think the modified Mohs procedure that Dr. Barr has helped pioneer here at OHSU is superior to helping us find the edges of that melanoma so that we have a one and done surgery. That's the aim, that we don't leave a positive margin and have to go back. So that's sort of how I start to think about how I counsel my patients when we get a melanoma back and understand the thickness.
Mm-hmm. Good, thanks. So I have a first question for Dr. Barr, and I think you've sort of covered this a bit in your presentation, but if you could just sort of summarize it real quickly. The question is this: can you comment on the use of Mohs surgery for initial treatment of skin melanomas? I've heard differing opinions on this, and mainly I think it has to do with the time it takes for some of the melanoma-specific stains to work, which is longer than most Mohs sessions. Do you want to comment on your recent work on perfecting that immunostaining, or how that works?
Yes, that's true. So the immunostain does take longer. With our traditional Mohs sections, they take about an hour. And with the immunohistochemical staining, it takes about an hour and a half. So it can be a long day, especially if I have to go in 3 times. You can imagine that that can be a long day. But the benefit is that the patient's completely awake. You're talking to me the whole time. You wait in the waiting room. You can walk around and go to the cafe and have some food. So it's not as rigorous of a day as being under general anesthesia typically. So it is a long day, kind of like Dr. Hahn's patients have a long day when they have the sentinel node procedure with the injection first in the morning, and then, you know, it does end up being a longer day, but the benefit is that at the end of the day, we can tell you that the margins are clear, where most centers, they would have to wait at least 2 days up to a week to let you know if the margins were clear. So it's a trade-off.
Yep. Thanks very much. I have a question for Dr. Hahn, too, that was specifically submitted. Dr. Hahn, is there a great layman's book on melanoma with information including diet, nutrition, vitamin supplementation, exercise program, prevention, etc., for post-op patients?
That's a good question. If there is one, I would love to know about it. But as far as I know, I am not aware of any specific layperson's literature available in terms of discussion of all those different elements, which are very key things to consider. What I can say is a lot of it we do go over, at our clinic visit, and also with our nurses who go through pretty much a whole list of things to get ready for surgery and things to help you in the post-operative period.
Yeah, I think, and I don't know of a book that is a really, really good one that combines all of those things. So I agree with Dr. Hahn. I do believe, though, that it's best not to be extremist. That when you can, sorry about that, when you, when you're thinking about exercise, when you're thinking about diet, I think that moderation is the best plan. I think that anything that you do that's going to be extremist, sometimes there's a tendency to want to really do something to the max that you think is going to be beneficial, and I would just warn a little bit against that. You want to use moderation and do the healthy thing. Do the healthy thing, because if you can create the best health of your entire system by balancing all of those elements that bring good health, that's going to be the way to do it, rather than looking for a magic bullet, because there's not really one. Does anybody, Dale, looks like you were going to say something else.
Yeah, no, I was just going to just emphasize everything you're saying. I think that crucial for you to have, realistic expectations going in, understanding that, you're however you have your procedures, it's an incision in your body, and your body needs time to heal. There's nothing we can do to speed that healing up. And remember, tissue is removed, and in doing that, there's a gap. In order to close that gap, no matter what is done, there has to be tension at that gap. The question is, how much tension do we do? Do we do that? And, for people who are experts at being able to close wounds, you basically are able to do it such that the risk of issues with the wounds go down. So the reason why I'm saying that is that really you need to just give your body time to heal afterwards, and upwards of 4 to 6 weeks sometimes, in order to allow the scar tissue to set in, so that the tension lines on that wound are minimized.
Yeah, there's a really good question in the chat for Dr. Barr, and I just want to give her a chance to answer it in person, because I think I want everybody to make sure they've seen it. And the question, Dr. Barr showed some really scary photos in a way, because some of those brown spots are not that dramatic. They're pretty difficult to see sometimes, and she showed with the Woods lamp that's one way to highlight it. But the question for Dr. Barr was, how do you detect melanoma on the face if it's not visible, like a brown spot?
Well, as I mentioned in the comment, it is very difficult and very tricky. So I recommended the best bet really is to see a board certified dermatologist for a skin check. So that would be someone, not like your PCP type thing, but this would be really specialized dermatology trained doctor, such as Dr. Leachman, Dr. Berry, And we have a large department of dermatologists on the 16th floor at OHSU. And we're specially trained over 4 years of residency and possibly additional fellowships to assess the skin and make the best decision on what the type of spot is. That would be the most important thing. The second most, interesting advance in detection of early melanomas or melanomas without pigment is something called confocal microscopy, which is a special microscope that can be put right on the skin and gives greater detail of what the lesion may be than even your eyes can see. So that's another exciting advance, and you may hear more about that as OHSU is one of the pioneers in that as well.
Okay, those are great answers. I'm going to go back to the ones that were sent in. It says, please mention the devastation squamous cell carcinoma can cause. My sister's entire nose was removed by using Mohs, using cheek for nose construction, and extensive grafting for cartilage and skin followed. And I think that that is something we could probably talk a little bit about. Both Dr. Barr and Dr. Hahn can mention the recent, I really think there's an increase. We're seeing nationally an increase in these serious squamous cell carcinomas with people who are immunosuppressed. And I'd love to hear their input about the surgical, consequences of those really, really severe squamous cells as well as melanoma.
Yeah, squamous cell carcinoma has a mortality rate that's actually even a little bit higher than melanoma if you look at it worldwide, because it can be an aggressive cancer as well. So luckily, most squamous cell carcinomas are caught before they spread, which is great because then they can be treated with Mohs surgery. But if they have spread, then, again, we would get Dr. Hahn involved in the surgical oncology team to manage those. And luckily, we're making some advances in immunotherapy of squamous cell carcinoma too. So, the entire field is really evolving in an exciting way.
Yeah,
Dr.
I would
Hahn?
echo what Dr. Barr has said, that there are a lot of evolving therapies that are coming into play. Absolutely, squamous cell carcinoma, especially when it becomes recurrent, can be very, very destructive. And, one of the few techniques we had was just to continue to resect and remove recurrences as they develop, or for locally regional disease, take, margins and contiguous tissues. But as was mentioned, we have a new agent, cemiplimab, for instance, which is an anti-PD-1 agent, which we often utilize now up front for patients with locally advanced disease to try to cytoreduce those tumors so that we can try to do tissue sparing surgeries, or to potentially salvage organs that we wouldn't have been able to do before, as those patients who have responses.
Great. There was a really good question. It really isn't a surgical question, but I'm going to ask it anyway. And I think, if Dr. Berry or Susan Tofte wants to answer, or Anna or Dale, you can also weigh in. But the question is the chemotherapy cream an effective method to treat in situ melanoma? I have had 3 in situ melanomas surgically removed. What do you think about topical chemotherapy for in situ melanoma? I mean, I have my own opinion, obviously, but.
Well, so it depends on your definition of topical chemotherapy and whether or not you're talking about like preventing the in situ melanoma or treating it. From my perspective, there's a cream called imiquimod that stimulates the immune system that I really like for, areas where we didn't clear the margin, but there's just a little bit left, or areas where, additional surgery is just not going to be possible. So say, the margins abutting the nose, or we see a fair number of mucosal melanomas, like in the genital area, where the margins can be really, really hard to clear. And so It's not my first line treatment at the outset. I still think that my surgical colleagues do an amazing job of getting rid of melanomas, and that's sort of the gold standard. But if there's something that's in an area that's difficult to treat, or the other scenario is if a patient's very, very old, and they're not going to do well with surgical treatment, then the imiquimod is a consideration.
Yeah, yeah. I am kind of opinionated on this. I'm going to say what I think about this. So, in general, melanoma is different. A lot of the topical chemotherapies, they are absolutely fantastic for eliminating non-melanoma precancers and thin or in situ non-melanoma cancers, right? Like a superficial basal cell or a superficial squamous cell. I think it's fine to sort of start with the topical chemotherapy if you want to try that. But for sure, for actinic keratoses, those precancers, it really, really works to clear those so that they don't progress to a squamous cell carcinoma. But there's a major difference between non-melanoma skin cancer and melanoma in terms of the potential that those individual cancer cells have to spread. And melanomas do have that potential to spread. And so if it's possible to remove the melanoma in situ with surgery, that still is the gold standard. That's the gold standard, is to get it completely removed with a surgical procedure. But like Dr. Berry said, there's always exceptions to every rule. Humans don't follow the playbook, you know, and sometimes it's right up close to the margin of the eye or something, or maybe it is, it's just an impossible thing to do, that particular procedure that's going to be curative. In which case, you can either combine the best surgery that you can get with the topical chemotherapy, and I don't like topical chemotherapy for what we use with melanoma, because I think of topical chemotherapy as being 5-fluorouracil, one of the real chemotherapies that we give to people like with colon cancer. What we're applying actually for melanoma is topical immunotherapy. And that's the Aldara or the imiquimod that she was talking about. So that's my answer. I think that there's nothing wrong with doing it. Let's say you think you've got it out, but somebody wants to go that extra mile and apply some additional immunotherapy on top, just to make sure that there's no, because sometimes the margins can be difficult to tell if you've got the whole thing. I see nothing wrong with applying a little immunotherapy as an extra precaution. But as a primary therapy, I still believe that right now the first gold standard is surgical removal. So go ahead. Anybody else have anything else to add for that one? Because I really put it in there. Okay, I think we are at 2 minutes out. I have one last, Patrick, did you want to kind of close things out now? Do we have anything else to do before we close? Or should I ask one more question? What do you think?
Yeah, go ahead and ask the last question, and then I'll say my quick little spiel, and then we'll get people on their way.
Okay, it says increased risk of skin cancer for immunosuppressed people due to other medical conditions. What preventative or diagnostic measures are recommended, including vitamin or other supplements? I think, again, that one is not so, I'm going to take that question back. It's a good one, but it's not so much for the surgical specialists that we've got here. I'm going to ask this one that says, what are the best ways to check if melanoma spread to the lymph nodes? Stage 2 melanoma diagnosis, should the patient be seen by an oncologist after surgery? Quick, Dale.
Sure. Well, it really depends on what the status of the sentinel node biopsy procedure shows. If it's a negative sentinel node biopsy, depending on how the surveillance patterns are at your institution, surgical oncologist or medical oncologist can do that. The patients that are lower risk for recurrence, it doesn't mean the risk is zero, but it's just lower. If it's a positive sentinel node, you should definitely be referred to a medical oncologist not only for monitoring afterwards, but also to discuss potential therapies that can be added at that point for the positive sentinel node, and also discuss with your surgical oncologist, discuss the role of potential lymph node dissection at that point, although probably less than 10% of patients nowadays undergo that procedure.
Okay, I think that this is a wrap. This is a great conference. I really enjoyed hearing the data as well as the actual practical things about how the surgeries are done, and seeing some of the examples was fabulous. Patrick, I'm going to turn it over to you. Do you want to thank everybody?
Absolutely. Thanks everybody for coming. It's always a pleasure to be able to get in front of such a nice large audience. I just wanted to point out we do have, thanks to our supporters here, and we do have one more virtual roundtable event for the summer. And I know this one is a pretty exciting topic that a lot of people are really interested in because it's new, it's exciting, and it's our advanced imaging that we've sort of been working on a long time to implement here at OHSU, and being one of the first centers on the West Coast to be able to utilize digital imaging to help diagnose skin cancers at their earliest stage without needing, a biopsy to begin with. So this is Tuesday, July 27th at noon to 1. It'll be Dr. Alexander Witkowski and Joanna Ludzik who co-direct that center. And if you haven't registered for that already, you can go to our War on Melanoma website and go to our events page, or we'll be sending out an invite for that as well. So we hope to see everyone there as well for another really exciting topic.
And this is the one that Dr. Barr was mentioning just a minute ago, that microscope that you can actually see microscopically at the cellular level by putting it on your skin. So it's kind of cool. So it was one of the answers to the questions that was posed today. I love that. All right.
Enjoy the rest of your week, everybody, and we hope to see you in July.
Thanks a lot.
Take care. Thank you. Take care.